relation to Jenny. So, Phil, are you a member of the public? Hello?
I'm Phil Corrie from the Sentinel.
Okay. Any particular reason why you're here, Phil?
Just covering the board meeting.
Okay, lovely, welcome. So we have apologies from Eric, but we have Lisa, a very capable deputy who will take us through the financial papers, and we have an apology from Nicola Bullen. Unfortunately, this was going to be Nicola's last board meeting, unfortunately, because she can't attend today. So we'll perhaps see her. She may call and see us in April. Any other apologies? I think we've got everybody else. Welcome to Chris Lake, who is here as part of our ongoing board development.
Morning, everyone.
You all know Chris. So he's going to be observing the meeting today. So any declarations of interest or changes to be notified? No, thank you. Meeting minutes from the 15th of January. Seems like a while ago now. These have been reviewed. Any amendments, omissions, corrections?
There is a couple of typos, but I can pick that up.
You picked up with Lisa. Thank you very much. Anything else on the minutes? We'll take those as approved subject to those amendments then. Thank you. Matters arising and the action schedule. So we've only got one. This was a question from a member of the public, and the action's complete. You've responded, Ben.
Yeah, I offered to meet soon, but the health ops managers, they've got to work that she'd like to complete first, and then we can see. So we've arranged to meet once that's completed.
Lovely. Thank you very much. Any other actions that we've not captured? No? Great. Thank you very much. So we move then, if you would, Kenny, on to patient story, please.
Yes, thank you, Chair. So just to introduce this board meeting's patient story, this is Richard's story. Richard is actually a member of our staff. He talks about an experience over 30 years ago now, when he had a really difficult time, which brought him into contact with our services. He reflects on his, I guess, recovery journey, his experience of being supported in terms of helping him focus on positive things and his mental health recovery. Particularly talks about the role of mental health liaison, mental health nursing, and also the benefits of therapy and understanding things like your childhood and how you think and how that affects your behaviour. So that was a real turning point in his life and inspired him to pursue a career in mental health, which he has done for many, many years now. So yeah, it's a fantastic story, and I think there's lots to for the organisation to learn. And I'd like to thank Richard, who isn't here today, for his bravery in terms of telling his story, so that others might learn from it. Thank you.
story. And I know it's been seen at the Quality Committee, hasn't it? Yeah. Any comments, thoughts for Kenny on Richard's story? Yes, Liz.
Thanks, Matt. I mean, it's quite emotional, isn't it? I feel a bit choked. What a fantastic story, and to have Richard working here and using that influence to make a difference is so incredible, really. Something that sort of struck me was the role that parents play, not only, I suppose, about influence and power, especially when you're a child and a young person growing up in that environment. But I thought more from a process perspective, Kenny, and I wonder if you might share a little bit more about how we engage with parents at the point of maybe assessment or treatment, and where that choice comes in, and there are different sort of rules around age limits and things, but I suppose can be either really supportive and helpful or actually quite detrimental. So just a little bit more about what our sort of policy is on that, really.
Yeah, thank you. I mean, I think this is an issue that is as real now, and it has been all my career, around the aspiration in every assessment is that there would be a holistic assessment which involves, you know, parents, carers, family, etc. I'll come on to talk about children, young people, and the boundaries and things there. But there are occasions where individuals do not wish for parents, family members, carers, partners, etc. to be involved. Now, it's a real skill trying to judge that. As Richard talked about, I think the psychiatrist involved picked up on it without him saying and just offered it. And I think there's a real skill in that, a real balance. However, what I would say is that even if an individual says, I don't want my parents involved, it doesn't stop clinicians speaking to parents generically about, okay, what's your experience of this person? You know, without divulging information, there's still a communication channel that can be explored, which is really, really important. And in terms of children and young people, there's a real quandary around competency. So there's a judgment about, as child gets older and gains their own competency, how that person can make choices about parental involvement and so on and so forth. So people working with children and young people have got real expertise, not only in the clinical practice but also in the legal aspects of how you work with parents. But the aim always is to include them, but there will be occasions where the individual has the choice whether to involve them directly or not. But that doesn't mean that prevents us from communicating with. And that's always a tension in mental health, and that's something that we continue to do development on and educate and build on, really.
Thanks, Chair. I suppose really, like I say, Liz says a sort of heartwarming but heartbreaking in the same way story, but I think it just reiterated to me the importance of spending the time with communicating with the, you know, for someone 28 years on to be able to reference a sentence that really meant something to them, you know, obviously a key moment in life, but I can't remember a conversation I had last week, never mind 28 years ago. So I think it just really reiterates, particularly when people are busy, and actually the importance that moment can have with patients. So it was great to see that come through, just a good reminder to us all.
A couple of things, just coming back to a bit about parents or family members and confidentiality and so on. It's something that clearly can be done well and is often also done very badly. Thinking back to parents that I worked with in the past whose family members were in hospital settings and so on, and they were sort of excluded from discussions. And actually the other day, talking to a neighbour who was telling me about her experience of her daughter having mental health care a long way away from home, and them kind of being shut out. Managing that boundary, as Kenny, as you said, is really important. And I think when it's done badly, I think I was aware that professionals, staff and others didn't seem to think this was any of their business. It was just clear cut, you know, confidentiality, we don't speak to parents. Managing that boundary and managing being able to sit on both sides of that is actually a really important skill of what we do, and I think sometimes it doesn't get emphasised and trained and supported enough. The other thing I was going to come back to and say before that, I think the story, underlying all that, the power of human relationships, that's fundamental to clearly that experience. He had a new experience of being accepted and listened to, supported by somebody in a way that had felt unfamiliar. And that's absolutely fundamental to what we do. Pity about the discontinuity then when somebody leaves and says, oh, I'll refer you on to a colleague. The first boss I worked for in the learning disability field used to say, actually it's always about putting one hand into another. You don't just leave something, refer something on or say, oh, I'll get someone else. It's really important to actually make those connections, otherwise people can be left adrift. And fortunately for him, that disruption wasn't catastrophic, but perhaps he was robust enough in the work he'd done already to cope that. But it really is important, continuity of relationships.
Thank you, Roger. Rose.
Thank you. Really inspiring recovery journey, and there's just a few things that I was sort of reflecting on in terms of his experience, and the things may have evolved since then. But I thought one of the points was around the reference he made to having been discharged from the service on the Saturday and being sent home with the support of his mother, and having a follow-up appointment for the Tuesday. And I was just thinking, during that time frame, and things may have changed, a lot could have happened between that Saturday and the Tuesday. What sort of support was there, and was that as a result of reduction in his risk to his health, or was it more indicative of the fact that those services weren't available until unless they were on a weekday? And I know that we still have variability in terms of when our services are available, so that would be something that would be just helpful to get to kind of understand how would that have worked now. And the other bit that was just related to that was the kind of the support that we give. I know we're really good at giving support to people who are formally recognised as carers, but how do we give support to the our community in general to recognise the signs that somebody is in distress? And if they were in a circumstance similar to the one that Richard found himself in, where he was really fortunate to have that young man sort of there to support him, can we reduce the possibility for variation in that experience for others by playing a more active role in raising awareness within the community about how sort of mental health can manifest itself, and the support that people may be able to do? And I know that we're not going to be able to train them to be mental health practitioners, but maybe something that we can do from an educational, developmental perspective that helps improve that awareness.
I mean, it's short as a reply. I think this is story's fairly old, so in terms of Richard's, I can't sort of answer that. In terms of the facilities and services that we've got now for people in distress, the expectation would be that absolutely that clinical assessment of presenting symptoms and level of risk would determine whether that was an acceptable period of time for someone to be without direct support. There's an opportunity in mental health services for people to be followed up through home treatment team, community mental health teams, be seen as an urgent review. So that's kind of where we're at. I think in terms of community resilience and some of the things that we've done as an organisation, one of our strategic priorities has been access. So we have made great strides, I think, in recent years about making it more easy to access our services. So things like our crisis care centre, where we've seen a huge rise in demand since we implemented that model, which I think has made a big difference in terms of people being able to access support very quickly. NHS 111, people can pick up the phone in a mental health crisis and get through to, again, our crisis care centre. And I think we've done quite a lot of work. I mean, Richard, his experience was actually, ironically, primary care CPNs which was a historic arrangement,
Yeah.
but is actually very, very close to the mental health R's practitioners, which we've got in place now. I mean, you spend so long in the NHS, things do come round. But actually, we've got many, many routes, whether it's through general practice, whether it's through 111, whether it's through crisis care. But I think there's always more we can do. There's always more that we can do in terms of engaging communities, particularly communities that we haven't traditionally engaged as well as we could do. So we can do more targeted work. But I think we've done lots of work in that area, and that's because it's been one of our strategic priorities.
So I've got 3 more people who want to speak. So Dennis, then Martin, Pauline.
Yeah, thanks. Yeah. I'll try not to repeat what others have said, and I think I've watched this video a couple of times now, and tried to. Well, my initial thought was to try and remember where I've met him before, but I couldn't remember where I've met him before. But he obviously references one of the key principles we use in psychological therapy, and he talks about unconditional positive regard, which we take for granted sometimes these days in the rush that we have, and the way the services are structured. And he also cites, like Kenny said, the primary CPNs, which were well loved by the GPs locally, and it was quite a challenge. But also, if we look at how the services have developed over time, I must say to get a year of counselling now is probably nigh on impossible, really. And that takes me back down to what I wanted to talk about, which is about discharge, and because he talked about discharge and how disconnected that was, and it's always difficult. And my personal experience is that I rarely actually see patients who are willing to be discharged from mental health services, and so it does then present difficulties for clinicians about how you do that. And maybe it might be unconsciously that the staff was using the time that they were leaving to discharge them without actually telling them they were discharging. I mean, obviously, we can think back now and say that was inappropriate, but of course we weren't part of the conversations and how things worked at the time. But yes, I think that's what, an area that we continue to have some form of difficulty with, and we just need to recognize that there isn't a straightforward way in terms of how these things work, and that there are different approaches that might suit different people at different times.
Thank you, Dennis. Martin.
Thank you. So just a couple of other points I wanted to just touch on, if I could. Really impactful story, and great to hear that Richard is now working with us, which is fantastic, and we all acknowledge the significant value that lived experience brings into our organisation. I suppose I couldn't help, and I did sort of a quick whisper to Fraser to think through, when we've got individuals with lived experience working with us at organisation, have we got the right wraparound support for them? I suppose question mark, not too sure, and again I'm sort of keen to sort of further explore that outside of board and possibly in PCDC to understand that a little bit more. And then my second point that I just picked up, I find it really interesting that for all the right reasons, Richard wanted to seek out, identify and make contact with somebody who'd helped him, and he was very easily able to, through social media, identify and make contact for all the right reasons. That there sadly will be occasions when people want to make contact for all the wrong reasons, so I did just think it was one that just might want to make us think around that social media side. And I know we've got an agenda item for Ben coming up in a couple of agenda items time, whether it is worth just having a think around social media, what advice we give to our staff as to, kind of thinking through, easily identified, etc. It's just, sadly we're in a different world now, and I do think that social media piece and being able to be easily identified is one that we need to be comfortable giving the right advice.
Hold that thought, come back to Joan in a minute. So, Pauline.
I just wanted to pick up the discharge bit to say that, this was 30 years ago, and that my understanding is, whether it be in mental health or any sort of health NHS services, is that almost from day one there is a focus on discharge, isn't there? And that actually how do we get this person with whatever their needs are to the point of being able to be independent, or if not totally independent, to have adjusted and adapted to be able to live with a level of support. So I do think there is a greater sense around that now, and I just, Kenny, I'm assuming that you know, is part of the sort of recovery model, etc.
I'm happy to pick up Pauline's and then the first part around peer recovery, if you'd like. I think we have made bounds in terms of understanding and having conversations with people early on in a process, early on in a referral pathway, to say these are the sorts of interventions we might be able to offer you, this is the likely time that this would go on for, etc. It's not perfect, and there's always exceptions to the rule because we're person-centred, but actually those conversations do tend to start much earlier now and up front, and that's part of, as you say, the recovery model and some of the work we've done around pathways and clarity. So that has improved, but it's always, as Dennis said, a difficult conversation because ultimately, as Richard described, some people will very much take huge value from these interventions, and ending them can be difficult. On the peer recovery, so we have got people in peer roles with lived experience as their contribution in terms of clinical services, and we do have a peer recovery worker network which has got supervision built into it. That's one-to-one supervision. It's got network, group supervision, etc. However, we have got many of our colleagues who are not in formal lived experience roles who have got lived experience, and so I think there is definitely a thing about how can we make sure that all of our supervision arrangements attend not only to the job and clinical practice but also the care and support of individual health and well-being. So it's a really good point, and we can pick up a further conversation around.
If we pick that up through PCDs, John, if you're okay.
That's fine, yeah. Yeah, everybody's happy with that? Okay. So, Joe, on social media?
Yeah, just a very quick thing, just to update on social media policy, Martin. So we've got quite a comprehensive social media policy that was updated, I think, last year. Though it primarily focuses on the actual content that is produced, and it does have guidance about bear in mind. You know, you can be identified, but we can certainly review that to see whether or not we've got that aspect of it in terms of you being identifiable. We can certainly review that and review it with involve Ben and Fraser in that. I'm not entirely sure if we've got an HR policy about it, but we can double check that and, if necessary, update the policy.
Okay, that'd be great. Thank you.
Bucky.
Thank you. When I saw the story, and like everyone has said, it kind of just reminds us about what we value in terms of working in mental health, which is around relationships. I think for me personally, I think Dennis was saying, you're trying to remember where you saw him. I was trying to think about what I was doing in 1998. And I think that was my first SHO job, if anyone remembers that, here. And actually, when you're in it, as we have been in terms of being long in terms of mental health, it's sometimes difficult to appreciate the improvement that has happened since then. And I was just, every experience he talked about, I was thinking, wow, we've got so much in place now. But as Kenny said, there's still a lot more we can do to improve. And I suppose it was just a kind of reminder to us all that, you know, we have done quite a lot since then in mental health nationally, but actually also in this trust.
Excellent, thank you. Really good discussion. I think nearly everybody's had something to say on it, so it's obviously touched everybody's hearts and minds. I think for me it's the power of the personal experience and the power of sharing that. It's great of Richard to do that. It's very, very helpful. There's some good actions out of that, which I'm sure we've captured and will be picked up. And I think also reminds us, as you say, Bucky, why we're here, why people are here. And to see someone go through a process like that and come out of it to a new life and a new career is really very powerful. So thank you for sharing that, and please pass thanks on to Richard. I don't think I've ever met him, but it would be nice to meet him sometime. Yeah, okay. So our next one is the Reach Recognition Team Award.
Thank you, Chair. We have Sam Dawson, who's here representing the team. We were talking about you before you arrived because we recognise that your job is so busy that we thought there might not be anyone here to represent the team, but really pleased that you are here. Now, just for context as well, this is a corporate team award, and what happens is, rather than us marking our own homework, we ask the directorates to nominate and tell us who they wish should receive that. So that's a great recognition for you. So I'll again stick to the script because I think it's important that you hear what people have said about you. So in terms of the team, what they do for us is that they ensure that we are compliant legally and provide guidance to staff with regards to the Mental Health Act across the tribunals and hospital hearings, liaise with external agencies, including local authority, courts, regulators and advocacy services. They're nominated because the team deal with complex cases and are regularly exposed to emotionally sensitive, distressing or upsetting information. And they do this because they care. They are committed to supporting colleagues to deliver the best care possible and support patients and families through what can be one of the most difficult times of their lives. We were asked to provide 3 examples of what they have done that have made a difference, and there is the introduction of the electronic mental health, which will create efficiencies both from an administrative and clinical perspective, improving tribunal and hospital managers' hearing processes. And the evidence is that there has been lots of positive feedback from clinicians. And I know they put clinicians here, I will go as far as saying it's medics, and I can say that as a doctor, because they are considered responsive, knowledgeable and reliable. Prevention of unlawful detentions and ensuring compliance with Mental Health Act within legally required timescales. And what's next for the team? To grow knowledge and skills that will be further disseminated through training and delivery. The team will be instrumental in guiding the trust through the new Mental Health Act reforms. Can I ask us all to join
I'm sorry, Sam, you have to be photographed. So come out the front with me. Well done. If you keep the doctors happy, then you're doing well. So, congratulations. Come on, Joe. Thank you very much. Well done. And thanks to the team. Thank you.
Well done.
Very welcome to stay, Sam, if you want, but I'm sure you've got lots to do. Absolutely to you. So now we come to your Chief Executive's report, please, Bucky.
Thank you, Chair. I'll take the report as read, point out some developments since this report was written, and highlight some points that I want the board to note. And the first to note is the national context in terms of the CQC report, and particularly the perspective as regards combined on that report, and wanted also to mention the veterans accreditation, the Mental Health Nurses Day, and one development since the report was written is the annual patient-led assessment care environment, which is place, and I know that Kenny will be able to talk some more about that if needed, but again that we have not only maintained our very high performance, and we have maintained a very high score in all areas, with 7 of the 8 domains exceeding the Mental Health Trust's benchmarked average. And particular note is the dementia-friendly environment and cleanliness score at 99%. Could argue that that's 1 point short of 100%, which no, would say that it's very good indeed, and we should be proud. So I'll stop there and take any questions or comments there might.
Thank you very much. Right, we've got Russell, Dennis, Martin, Prem.
Yeah, thanks for the report, Booking, really good, thank you very much. I was looking at the veteran stuff, and I think it's Ben, isn't it?
Yes.
So, because I was following a lorry along the A50, as you do the other day, and I happened to just see at the back of the lorry a strap line that said, "We support veterans." And I thought, what does that actually mean? What does that mean for a haulage firm? What do they do to support veterans? And then I thought, well, what are we doing? And I know that there's all sorts of things that we're doing, but Ben, are you able just to give us a snapshot right now about what we're doing to support veterans?
Yeah, so I'll give you a quick summary, and then the annual report will be coming to board in May. I think it's on the cycle for, so we'll give an update. But I suppose, so as part of the Veterans Reaccreditation, so we have an external assessment of how we're supporting veterans sort of in sort of 4 key areas. So one is veterans as a veteran. Well, it says veterans, but it's actually the armed forces community. So it's people who are serving, veterans and their families and close ones. And I think that's really quite important, because some organisations have just focused on the veteran themselves, and actually it's bigger than that. So the first area is how we support them as patients. So we've had a huge drive to identify them in our data. We've got about, I think it's about 60% have got a field recorded, which is still a long way to go, but we've only been recording it for 2 years. So actually, when we compare to other organisations, we're hugely further, and that's because people have built it into what they do as the norm. So that's is allowing us now to start identifying where we've got key areas where we've got higher prevalence of people accessing a service, or indeed lower. And we've built in, so there's a specific course we've brought in the Wellbeing College that we brought in as a result of feedback from veterans, that now some veterans are helping us run, because we've worked out with them that actually they will only interact with their own and open up in the same way, and they recognise they talk a different language. So there's a whole provision around service provision for our patients. There's another another area around our staff and identifying them and offering them support, and we're about to do another step in that journey around offering them some support and identification. There is a further aspect which is actually engaging with the armed forces, so that's both things like Defence Medical Services, which is based pretty much down the road just outside Tamworth, but also things like the cadet services, etc., locally, and how we integrate them. So we've done some sort of mental health sessions for the Sea Cadets, which interestingly is our local cadet organisation, even though I don't think we could get much further away from the sea, but it is our closest cadet organisation. But we've done some work with them around mental health, etc., so reaching out to the community. And then there is some wider work around the local community as well, and reaching out and working with multi-agency partners. So it runs across a number of areas. And I have to say, we started this journey 3 years ago, which is why we've just reaccredited. And the feedback from the national team is we have gone from sort of 0 to 110 that we've, and what I will say is that's not me, and it's not that it is, we provided them an enabling structure, and then the clinical and operational teams have just ran with it and ran hard, and they've kept going, and we've done a sort of, the reason we've continued to do an annual report is just to take that bit of time to reflect just how much we've done in the year, because it was only when we sat down and thought about it that we sort of recalled how much we had done. So there's still a long way to go. It's still a disadvantaged community, but we've made some real steps and we'll continue to do so. And just to add, we have just put in the application for our Goals ERS award, which is for us as an employer. So we had bronze, we got silver. There are sort of certain time periods before you can go up the levels. So this is the first time we've been eligible to go for gold. So we've just last week submitted that. So we wait to hear that as well, because that's the other thing we can go for.
Thanks, Ben. I won't ask any follow-up questions because that was a
It's covered
comprehensive
it all.
answer. But also, we've got a paper coming in a couple of months' time. So that was just a really good summary.
Thanks very much. I'm going to go Dennis, Martin, Prem, Fraser.
Yeah, thanks. I just wanted to mention about detentions of patients from global minorities, particularly black patients, and it is really heartening to see that within the trust that we are not detaining more against compared to the national picture. But obviously that is something we continue to monitor, because there are also beneath that some evidence that we admit more and that they are more likely to present in crisis and quite late. So there is still some work for us to do as an organisation to just make sure that we continue to perform at that level and not detain more, but the admission rate is still a concern.
Thank you, Dennis. Martin?
So a couple of points if I can. So thank you, Bucky, for the report. Really informative, but also thought-provoking. So it was linked to Dennis's point there. I suppose it's the inequality piece for me, and there's some inequality included in here, but I suppose we're just trying to think and challenge ourselves as an organisation. Do we see enough data around inequality at the moment? I don't think I do in the committees that I sit on. I can't comment for Q&S, but I think there could be an opportunity for the organisation, but welcome others' views around trying to get to a position where we've got more data, relevant data coming in around inequality, so that we can truly understand where we're doing well and where we need to make some improvements. You know, it's great to see. It appears that ethnicity breakdown of people. It's great to see in relation to areas of deprivation that data shows that in deprived areas where people are being seen quicker. That's great to see. It would be even better to truly understand why that is the case, and are there any positives for it. So I think that inequality data piece for me, I'd welcome some views on that. And then my second point, again, great to see the monies that the trusts have awarded to VCSE organisations, which is brilliant, and the difference it will make out in the communities. The only bit I'm keen to understand there is, do we close the loop on that to get a proper understanding around, so what difference has that funding made for each of those projects and organisations, and most importantly the community? And I'm not too sure where we get that loop coming back into the organisation around the impact of that money and those projects.
I'll start now. I'll ask Kenny and Liz to answer or say some more. So with regards to the inequalities piece, it's the PCREF mainly, and we've been involved in that process both as a national requirement. There's always, as you might expect, more that we need to do, and even if it's good, like Dennis said, we're never complacent, because even if it's 90%, that means there's 10% left. But you know, Kenny and I were talking yesterday, and he'll say a bit more about that.
Yeah, so the patient care race quality framework has been around probably for over a year or so now. So we've been looking at the framework itself internally, and the first step that we really took was to improve our data and data quality through the record, because what we found when we first started to look at this a couple of years ago was we had gaps in some of our data around ethnicity, And so we've really improved on that and done focus pieces of work with the directorates around improving the data quality, and we've got good data quality. It can still be improved, and we've got a comms campaign coming out about continuing to improve that. But as Dennis said, what we have noticed, at least at a trust level, and we've done some work at directorate level as well, is we don't appear to have really any significant, I would say, racial inequality in the priority areas that we've looked at. So we've looked at 3 priority areas predominantly. We've looked at the use of restrictive practice and ethnicity. We've looked at mental health act detentions and ethnicity, because they're 2 issues that we know nationally are real challenges for mental health organisations. And we are looking at that on an ongoing basis, but the data we have so far says we do not have, at a trust level, significant inequality. However, what we are now wanting to do is embed an approach to inequalities, which isn't just about race, it's about all inequalities against issues, and being able to drill down lower into the organisation into more detail to say, actually, have we got in a service more inequality around either access or use of restriction or whatsoever. So at a trust-wide level, we are in a good place, but we've got more developmental work to be able to do in terms of that. And also we have got a self-assessment which we've just done with all our service lines to look at the standards that sit within the PCREF to say where do they think they are in terms of strength or areas for development. And actually I'll touch on that this afternoon in our board development session, but we are going to be bringing that through more regularly in the annual reports that go to Quality Committee. And we've already got that embedded in some of those reports, so Mental Health Act and restrictive practice and incident data, where we are looking at ethnicity as well within those reporting cycles. Hopefully that's helpful.
Okay, thank you. So Liz, did you want to say anything about charitable?
Yeah.
It's not charitable, but
Sorry,
the grants.
The grants.
Yeah.
Yeah, sorry.
Yes. So this has been a really comprehensive programme that is coming to an end, and was about putting some of the investment back into the VCSE sector, with the caveat that it hasn't counteracted the money that was taken out years and years ago, so still not enough. But you see some of the data there and some of the impact that it's had on individuals. I think organisationally though, it's really had an impact on our role and our ability to commission and work in greater partnership. And I think that lays some really good foundations as we move into the place agenda. One of the criteria for people to access the grant, for organisations to access the grant, was that they built in a sustainability programme, because it was only ever short-term funding. So how they were able to sort of sustain those services and wrap around communities and individuals, which is part of what we've seen. And then I suppose the final point is just thinking that we've seen a real shift from secondary mental health care. Demand continues to increase, but now actually thinking about how mental health is managed more at a local level, at a more community level, which prevents that escalation. What you want to know is the evaluation and the impact, Martin. We did do an impact report last year that came to the board, and that was halfway through the grant programme. We will do another at the end of the programme this year that sort of closes that loop and gives some of that real data and analysis of the impact that this grant funding's had, and then what actually we're going to do moving into the future to sustain some of those relationships, work together at a more local place level, given the investment that we've made.
Really crucial, and I'm also looking at it from a place perspective moving forwards, and what's the opportunities to understand what's worked, what hasn't worked, what's been sustained. So yeah, thank you. Look forward to seeing that.
Thank you. Pram.
Thank you, Chair. I think Martin's covered quite a lot of the points that I was going to make around inequality. So I think anything we do on the data and getting an understanding of the data and the layers, but also I think the communities in terms of how engaging they are, because some communities will not necessarily want to do their dirty washing in public. Certainly from an Asian community, you wouldn't, somebody's got mental health issues, you wouldn't want to engage, but you don't want that to be known. So I don't know whether you can cover that dynamic through some of the data. The second point is unrelated. It's to that letter you sent out last week. I just want to thank you for sending that out about global events. You know, a lot of people will be impacted, whether it's family or friends, you know, whether they're in that area or not. But I just want to sort of personally thank you for doing that and endorse that. Hopefully the board will endorse that message and support for our staff.
Thank you, President.
Yeah, so it's so slightly going back, it was just a plea in relation to the veteran aware conversation that we had earlier. You can obviously see that Ben is leading on loads of stuff and we're actively motoring on delivering it. But if we are going to receive our gold accreditation, then we would like to have your support in engaging with all the networks that you're part of outside of the trust, in order to show advocacy for veteran aware, what can be done, and to offer our support as a lead partner or peer sort of support mechanism, because that's one of the things that helps contribute. We have that to offer anyway. It's a strength for ourselves. We're happy to share that learning, but it's one of the things that will help us to achieve the gold accreditation. So yeah, a bit of work back for you, I think. Thank you, all of us.
Fair enough. Okay.
I just wanted to go back to the inequality and just to confirm that the Quality and Safety Committee does actually discuss on the reports where it's available, like restricted practices sector, as Kenny said. You know, we do look at that and we do discuss the data that's presented to us. And I think, Kenny, you mentioned about the framework, and you know, we could actually embed that as an agenda item on a part of the cyclical business of quality and safety, because I think that actually would be really useful to do.
We can ask for it to come to the next committee.
Okay. Katie, I think you were next.
Again, inequalities. I was going to mention this later in the papers, and Pauline's possibly just picked it up, but in one of the committee papers we've got a comment about equality impact assessments and how we use them. And I think it's really good to hear about, you know, how we're going to continue to use data, because I think it should be a thread through everything we do. Now, obviously, primarily we're a mental health trust, but, you know, viewing equality of inequality in a broader way, and particularly trying to move towards intersectionality. And I think having that approach of really understanding the impact of what we're doing and those changes that we're making, whether it is to do with policy or whether it's to do with, you know, IQPR and the information that's coming through, but really getting into sort of business as usual, that it's really embedded throughout, I think would be really helpful.
Thank you, Katie. Thank you. Ben?
Yes, just I suppose a couple of points. One, it was just a flag in relation to the grant scheme when we had the system work supported by the Centre for Mental Health. The approach we'd taken to those grants was one of the areas that they flagged as an area of good practice in the approach that we've taken as well. So just a bit of external validation of that approach there. And it was just picking up on Prem's points as well around hard to access communities and world events or other events, is how we can use those potentially to our advantage though. So on the back of the sort of community challenges last year, on the back of that we did some work in conjunction with Staffordshire Police to reach into communities that actually resulted in a number of the local mosques actually inviting us in to have a conversation about mental health, and those have been groups we've really struggled to engage with. So much as we don't want to have any of the challenges we've got, it's about, if they do exist, how can we use them to further our options. So it was just a bit that was all.
Thank you, Ben. And Jenny?
Yeah, it was just to kind of build on the point that Katie was talking about from the kind of race equality side of things. I think from my observations, and obviously just looking at the deeper dive that we did here at Combined in terms of proportionality, I think was really important, and I just didn't want it to be kind of underplayed in that it was proportionate to the community that we serve, but actually so many other places don't do that and just say, well, actually, you know, it's high, the numbers are high, but actually they then don't reflect back at actually what that looks like in the community, and therefore your numbers might be high, but actually the population you serve is high in that particular demographic. So yeah, that kind of look back for me was really critical. So yeah, positive step there.
Thank you. Anybody else at all want to ask Uki anything about her report or comment? Very good discussion. Thank you. Thank you for the report.
Thank
Uki.
you, Chair.
You'll be pleased to know my report is much shorter. And it was really just to recognise the end of the work, or this stage of the work around Chrysalis. I know that we're hoping to do some more, but a great event the other day, just to celebrate with colleagues and external partners who have helped us to convert our inpatient wards to fantastic, airy, light, open, welcoming, comfortable spaces for people to come and stay with us when they need our help. And it was a great and very upbeat session. So thanks very much to everybody. But I think we just need to make sure everybody involved has the thanks of the board for all of the work that's gone into that. I talked about 3 board team visits, very enjoyable, particularly the one to the Mother and Baby Centre where I got to actually see some babies, which was really lovely. And also talk to some mums, more importantly, and hear what they had to say about interacting with the service and the difference it had made to their lives at a very traumatic and difficult time for them. And it was a very it's a great place, isn't it, Book? It's very upbeat, very light-hearted, but it does some serious work, but also interacts very effectively with other community outlets like the family hubs. So the things that came across in all of these interactions was really strong local leadership makes such a difference. You get a really good leader in each of these teams, transformative in the way that people want to stay. We've got no vacancies, we've got almost a waiting list for people to go and work there. And the fact that they'd realised that they didn't all know everything about what was going on in the centres. They set up an education scheme between themselves, which Bookie encouraged them to just can you raise the profile of that, because it's a really great initiative. People do have some issues that they want us to look at, and it would be very odd, wouldn't it, if you turned up from the board and there were no issues at all. So I suppose my only concern is that having done this for a while now, that sometimes I go back to the same team and they've still got the same issues. So I think there is something about sharing, perhaps at board level, not all the time, but say quarterly or half yearly, what actions we've been able to do, or if we've gone back to people and say, sorry, we really can't fix that one. So I think that's, I'm sure you've got it in hand, Nikki, but it's something that keeps coming up. So just worth thinking about that. Did you want to comment on that?
Yes, it was just to say that in May, board will have the Q1 end of year board to team report.
Okay.
That will include actions for the quarter and for the year going back. We do monitor the action log in our performance meeting monthly, so we take a good look at the action log every month, and obviously that's the meeting of the chief officers, whereby there's always a chief officer lead for the actions that are allocated, and we have some good conversation and challenge about when things aren't moving forward in perhaps a timely manner. So it's a really good conversation in the performance meeting every month. Yeah, so just to
excellent.
May I add something to that? I think one of the my observations is communication back to the team. Whilst we get the assurance, I don't know that the team understand, for example, if something can't be done, the reason why it can't be done. So that's perhaps something we need to strengthen.
More space is a common theme, isn't it? Can I have more space? Kenny?
Chair, so just I agree on the project Chrysalis Celebration event. We set out to do this 5 or so years ago when we originally bid for the funding, but we have now seen empirical data that shows a reduction in safety incidents that sat alongside obviously the improvements in privacy and dignity of eradicating dormitories, but while we were doing that we were also able to fit reduced ligature anchor point, top specification, doors, fixtures, fittings, and that is now evident that we have seen a sustained reduction in things around safety and instance and use of ligatures, and that I think is just testament to the investment, because it is not just about experience, which is of course very important, and privacy and dignity, but also actually safety.
Yeah, absolutely.
So, absolutely agree.
Yeah, and that comes across from the staff, doesn't it, as well? The staff are very comfortable and competent to tell you about the facilities there. So it's not just about nice chairs and colours, it's about how safe it is and the access. Fraser.
It was just on this point that Nikki just mentioned around the level of scrutiny that goes into the board toward actions, and I do think that we do review that regularly. One of the things that I've been reflecting on, just learning the lessons from the Being Open report that we do, that goes through a number of the committees, is that it's actually useful to take a retrospective view over a prolonged period of time of the thematic kind of view of what's coming out in terms of the categories of things. So if it's safety issues, training issues, infrastructure issues, because that then in itself tells us whether some of our governance processes and other things are working in terms of investment. And so that's something I'd value. I know that's a bit of work. It might be that we need to wait a little bit longer for that, but if there's anything we can do to support that process, I think it could be useful.
Yeah, we can absolutely do that. On the feedback form, there are a number of drop-down boxes for where people can tick the thematic category that they think that the action belongs to. Okay. So that allows us then to kind of put that into the machine and pull out sort of the themes for the 12 months. But if there isn't something there, if there isn't a theme that works, please just write in the boxes. It's not. It is just a dumb form. If there isn't something there that you think should be there, then please overwrite it. But yeah, in the drop-down of the feedback forms, you can pick categories for some thematic analysis that will come through on the year-end report.
Great, thank you.
Joe.
Yeah, just a couple of things. So on Project Chrysalis, we've got a final celebration film which you saw at the event, and that will be going live publicly starting next week. I was just doing the final touch, and I'll make the board aware of that. And then just you mentioned on the parent baby unit, thought you might like to know that thanks to some great support from Lisa and the finance team, we successfully been commissioned by the City Family Hub team to produce a series of films to support parents with issues as they access the service. But so we'll be doing that over the next few months. But that's the first time we've now been properly commissioned as an external provider of services, and that was thanks in large part to finance and procurement. So to them.
Excellent teamwork. Well done. Thank you for that. Anything else from anybody else before we have a break? Are there any questions from the public? Okay, so shall we have a 10-ish minute break, quarter